everyone. Thank you for joining us this pretty sunny morning. We're super excited to have Kim Keys here today. A tiny bit of background. My name is Anna Guida. I'm the project manager of Power Idaho, which is a program of Janus. We provide tons of trainings like this one with awesome subject matter experts like Kim throughout the year. So we encourage you to check out our future educational opportunities for both participants and providers of behavioral health services in Idaho. So without further ado, I'm going to pass over to Kim to allow her to give her a nice, introduction. But also, in terms of questions, feel free to ask questions in the comment or the chat in the question box, and then I will read them off to Kim from time to time. We also have closed captioning, so we hope that works out for you all, and we'd love to get your feedback on that also. So, Kim, it's all yours.
Yeah, that's great. Thanks, Anna. I appreciate it. Hi, everybody. Good morning. My name is Kim Keys. I'm a counselor here in Boise. I run a group counseling practice. There's about, 8 of us or so right now. And I'm also part of, most recently, a telehealth provider parity network, working on telehealth parity across the state. And I think, if memory serves, Anna, that's sort of how we got connected, as I was reaching out to a number of different stakeholders around the community to talk about telehealth parity and how we can set that up across Idaho. And so that's part, I guess, of how I ended up here talking to you all about mental health parity, how that came to be, and telehealth parity, and what we have currently and where we still have to go. So like Anna said, please ask questions at any time. I believe there's a chat box. I was telling Anna I don't really have access to that, so I may stop periodically and just ask her to read what's ever in the chat box. So please be patient with me. Anna, if you feel like there's one that comes up that is pertinent to what we're talking about right then, just interrupt me, because I tend to keep going pretty quickly. So
sounds good.
Okay, great. So yeah, this morning we're going to talk about mental health and telehealth parity. My hope is that we can give you a definition or a really good understanding of what parity is, what it applies to, how it applies to telehealth, a little bit about the history, how we came to be where we are today. As we do that, it becomes really important to understand how insurers work, your insurance benefits, those kinds of things, because what parity is, what it covers and doesn't cover, it helps to understand insurance benefits in order to understand how parity works. So we'll go through that, and then we can talk about some of the common violations that we see and some resources to help you when and if you come up against those violations. Okay, so that's my hope this morning, and we've got about 90 minutes to cover it. It's a lot, so I'm hoping we can get through it pretty quickly. So in its most basic form, parity just means equal in status and pay, okay? So for years, we have had what are called RVUs, relative value units, that on a federal level determine how much certain procedures, any medical procedure, costs. And it's based really on 3 things. It's based on what level of experience does it take the person to do the service. So my neighbor's a surgeon, okay? When he goes in and he operates on a knee, what is the level of experience or education is required for him to do that and for me to do my work as a counselor? That's 1. Number 2, what are the cost of the materials to do the service? That's number 3. When he goes in and operates, he needs an operating room, he needs a scalpel, he needs all of those things. I need an office, right? So less materials that I need. And then number 3 is, what's the liability? If something goes wrong, what's the liability? His is much more than mine. So those 3 things go into what's called a federal RVU, and that's what determines the cost of what a particular medical service is paid, okay? What parity says is, hey, mental health services and sub-services need to be paid in the same way, not the same amount, but in the same way as medical or primary services are paid, okay? So what does that look like? What that looks like is way back in the day, and actually still today, a lot of times we will see different allowances for visit limits. For instance, you can go see your doctor as many times as you need throughout the year, but your counselor, you might only be able to see them 10 times. We might see different deductibles or co-payments. Again, we're going to talk about that just a little bit later. We're going to get into the nuts and bolts about what that actually is, deductibles and co-payments. You might see differences in lifetime or annual limits, okay? Pre-existing condition limits. In the past, before mental health parity, mental health could be carved out as a non-covered pre-existing condition. So if somebody had depression, or if somebody had schizophrenia or bipolar or anxiety disorder, their health benefit from year to year could say, okay, we'll cover everything that you need medically, but not for this particular condition, okay? Mental health parity covers that, requires insurers to provide the same level of benefit. So if they're not going to limit primary care for something like diabetes, okay, then they can't limit it for depression or schizophrenia. They have to either do both, or they can't do either. If they're going to limit visits for one, they have to do both, not one or the other. Does that make sense? If there's a prior authorization needed for you to see, if there's no prior authorization needed for you to see an eye doctor specialist, then there should be no prior authorization needed to see a specialist for, let's say, your bipolar or eating disorder. So that, in its most basic form, is mental health parity, okay? Telehealth parity, we are working on, because it's not in place at all as of yet, is the same pay and treatment for services provided in person as they are via telehealth. Okay, so if somebody comes to my office and sees me as a counselor, if you go see your doctor and you have a visit with your doctor, that if your doctor visits with you over video call, that it's paid out at the same rate, or there's no, again, back here, there's no limits to those visits, the deductibles are the same, they can't charge you a higher copay, there's no lifetime or annual limits that are different than medical care or different than in-person care as telehealth care, okay? At its most basic form, that is parity, is that it's the same. Anna, how are we doing so far? Do we have any questions?
I am not seeing any questions at this time, but just
Okay.
quick refresher. So we have the question box and the chat box for our participants. Either or works fine, everybody. Okay, thanks.
Great. Okay, just interrupt as you need. Okay, and Empower Idaho had put together a training here, and there were a couple of resources. It was really good, actually. And there were a couple of resources I kept in this that I thought were really valuable. This is the first one we're going to watch, just a really quick video about what the APA and parity law does. Can you still see my screen?
Yes, we might have issues
Great.
with volume though, just so you know.
4 weeks ago, he broke his arm. Tom also has depression. Both conditions have had a significant impact on his life and the lives of the people who care about him. But when seeking help, Tom's conditions have not been treated equally. In the past, insurance often covered services to treat the body, while providing little support to treat the mind. Tom's insurance made him pay higher copays on his mental health care, and he faced limits on his therapy sessions. But our well-being depends on the healthcare system seeing the whole picture. The mental health parity law has given equal importance to the health of both body and mind. At last, Tom has equal access to the same mental health services as he does physical health services. He no longer pays higher copays, and he no longer has annual limits on his therapy sessions. So Tom gets the help he needs when he needs it. It's time to take care of our whole selves, and the mental health parity law helps make that possible for millions of people, just like Tom. Talk to your insurer or review your own benefits to find out if you're one of the millions covered by the mental health parity law.
Great. Let's see if I can get back here to our, there we go. Okay, so with that video, does anybody have any additional questions at all? Or I think people are pretty aware at that level what happens with parity.
I'm not seeing any right now, but I'll pop on if any come on.
Okay. I'm gonna go ahead and keep going and then just, yeah, interrupt me as you'd like. So here's the kicker, and this is where it gets really tricky, is that parity still does not cover a lot. There's quite a lot that's not covered, and so it becomes really difficult as a consumer, as well as a provider, to figure out and navigate this whole world, right? So what does parity not cover? It doesn't cover any self-insured or non-governmental group plans. Individual and group plans created or purchased prior to March 23rd, 2010, they call it grandfathering. That 2010 date is when the ACA, the Affordable Care Act, and mental health parity went into action. So any individual or group plans purchased before that date are grandfathered, really not grandfathered in, grandfathered out of parity. They don't have to include mental health as part of your essential benefits. Any employer-sponsored plan that receives the exemption based on cost. Here's what that means. Part of what was built into the ACA is that if an insurer could demonstrate a cost hit based on parity, and that cost hit really has to just be 2% within the first year. Subsequent years after that, they simply have to demonstrate that it cost them an additional 1% to include parity, and they're exempt from having to meet the parity requirements, okay? Some state and federal government plans are exempt from requirements for parity. Medicare, Medicaid are exempt on a federal level. Veterans Administration are exempt. It does not ensure parity of reimbursement, resulting in mental health providers choosing to be out of network due to untenable cost structures or low access to care. Really what that means is that because parity currently covers mental health, the services, mental health and primary care, but it doesn't say that it has to reimburse in the same way based on those federal RVUs we were talking about earlier. So what happens is a lot of mental health or behavioral health providers choose to remove themselves from networks. They choose to be out of network, which means as consumers, we go to look for mental health care and we have to pay out of pocket because we can't get access to providers that are in network. And that's happening more and more because the reimbursement is not commensurate with primary health. It does not cover telehealth services at this point. So those are some of the broader exceptions to mental health parity. Does anybody have any questions about that?
I do not see any at this time.
Great, okay. So it helps sometimes to get just sort of a rough overview of our history here with parity and how we got where we have gotten today. So really this work began in the early 60s, mostly with the Kennedy administration, and the Kennedy family has done a lot of work on mental and behavioral health parity. It started with simply requiring that the HR or the Personnel Commission require parity for their employees. That's really where it started. And from about the 1970s, even up until now, to varying different degrees, a lot of individual states, have made some changes to parity along the way, okay? You'll see that there at the bottom. On a federal level, you'll see that tracked here in the red, okay? So somewhere around 1996, mental health parity passed. Now, it was very, very limited. It was for large group employer-sponsored plans only. 1999, they expanded that to federal employee benefits programs. Okay, so now you had limited to large group employers and federal employees. Then in 2008, probably one of the most important, aside from the ACA acts of legislation, the Mental Health Parity and Addiction Equality Act expanded that even more, added in substance use disorder counseling, and started growing from just large group plans to some smaller group plans, but still not smaller or individual market plans. 2009, CHIP expanded over to CHIP, and then in 2010 is when the ACA, the Affordable Care Act, was passed, and that included behavioral health and substance use disorder counseling as part of what are called EHBs, your essential health benefits, meaning that an insurer, when they're putting together the benefits that are or are not covered, that mental health, behavioral health, substance use disorder has to be included as part of those essential health benefits. They can't be excluded. The ACA also expanded it to small group plans. Again, there's still a wide variety of plans that it does not cover, okay? Those non-governmental group plans, self-insured plans. So we still run into what are called self-insured plans. These are employers that choose their own, they don't go through an insurer, they choose their own insurance, and they can choose whether to allow for parity or not. So there's a lot of, even with ACA having expanded the way that it has, there's still a lot of exemptions to parity. In 2016, TRICARE eliminated limits and required equal cost sharing, close to parity. So remember back here, one of the exceptions is the Veterans Administration, Medicare, and Medicaid. We are seeing the Veterans Administration and Medicaid, not so much Medicare, a little bit, making some changes. I was looking through my parents' Medicare the other day, and it included mental health as an essential health benefit, which is great news. It still requires extra hoops that either a consumer, a client, will need to go through in order to get those services, or the provider needs to go through in order to put those services in place, things like prior authorization and things like that. So in those ways, TRICARE, Medicare, Medicaid are still not meeting parity, but they are making, you'll see here, they are making some steps towards it by eliminating some limits, annual limits. They can come in as many times as they want, requiring equal cost sharing, which means that your deductible or your co-insurance, if it's at this level with primary care, it's going to be at the same level or within reach, that same level for behavioral health. So that's good to see, as some of those entities, independent of being required, are putting some of those things in place. Now we've seen some movement as of late, since about 2018. Health and Human Services issues a plan to eliminate the harmful acts of ACA. What that includes, we are not entirely sure as of yet. The goal or the directive of HHS at this point appears to be to take away federal requirements and to put it largely in the hands of the states. So what that means currently for ACA and federal parity rule, we're not sure what that will mean going forward. Most of you know that a lot of that is tied up in Supreme Court cases at this point in time. And then in 2020, this is, I should have put this actually down at the bottom because it falls into some of those things that states are doing to kind of push parity forward, or lack thereof, to put some regulations in place. And most recently, I believe it was in April, the Idaho governor, Governor Little, issued an executive order regarding telehealth. Here's what's really important. That executive order helped to a huge degree with access to telehealth services. It removed a lot of the barriers that have kept telehealth services from being accessible and usable in the state of Idaho. However, It does not speak to parity. Again, parity being really, hey, insurers, you're going to need to pay mental health and behavioral health services, telehealth services in the same way as you would for in-person or for primary care. Okay, so I put this order on this time frame because I'm getting a lot of confusion recently about that executive order, because there's a lot of folks that I think believe, I'm coming to realize, believe or think that that executive order had to do with telehealth parity. And it didn't. It simply removed the barriers to access to telehealth that we had in the past. So I hope that that can clear some things up. So with all of that having taken place really since about the 60s and 2010 really being the time when the federal government said, hey, this is what we're going to work toward. We're going to work toward telehealth parity. And there was a time frame that insurers and states had to be able to roll out parity over time. So the question becomes, where are we and how are we doing now, right? So there is a nonprofit company, Milliman Inc., that did and is continuing to do a large data collection and looking into how we as a country are doing with implementation of parity. And in 2018, that first report was published, and it was pretty profound because what they found is that parity has simply not been implemented. General medical providers are paid 22% more for office visits than mental health or substance use professionals are for commensurate services. So again, my analogy earlier when I said, you know, my physician friend is a surgeon. Those are not commensurate services, okay? Psychiatric, commensurate services. So we look at same services, and primary care providers are paid 22% more. Medical specialties, another 19% higher than mental health specialties. So if you have a diabetic medical specialist, they're likely paid another, this is on top of the 22% higher that medical providers are being paid as opposed to mental health. That specialist is paid another 19% higher than a commensurate behavioral health specialist. The Milliman report found that 1 in 5 adults are still uninsured, still don't have insurance, access to care. Inpatient service receive out of network 4.2 times higher than mental health. What that means is that if I, as a mental health person, client, go looking for inpatient services, I'm 4.2 times more likely to have to get that care out of network of my medical insurance, meaning my medical insurance won't cover it. And again, that speaks to some of those first two bullet points, sorry, the second and third bullet point, where when you have a behavioral health network that is paid much lower in reimbursement, that's not tenable to continue a business. And so what those professionals do is they remove themselves from the network and go out of network so that they can keep their costs their costs covered. Which means that for our clients, for patients, we pay 40 to 100% higher for mental health and behavioral health services than general medical. And it means that clients, patients, are unable to access in-network care. It's very hard. I will tell you, as of right now, with you know, COVID and things like that, our community is really, really struggling. And there is about, most professionals in the field have about a 3-month wait list. That is enormous, especially when so many people are really needing help. So you know, we've got a 3-month wait list in the Treasure Valley area alone. Add on top of that, that when a client is able to get in with somebody, they may or may not be able to use their insurance. So this is a tough space to be in for behavioral health and mental health counseling, and needing some of that help, because we're still finding that we're paying quite an awful lot more out of pocket. Any questions
Hey,
before we
Kim, I
move?
have a quick.
Yes.
Yes, sorry, I was just cutting you off when we had the same idea. Yeah, so we have a question from one of our attendees, and this is what it reads. With Medicaid expansion in Idaho, how many more people covered? Okay. With Medicaid expansion in Idaho, how many more people are covered and how many people in Idaho still lack health insurance?
That is a great question. And I can get back with you about that. I did not look at the Idaho Medicaid network when I was looking at telehealth or mental health benefits. Well, in looking at Medicaid, I looked at telehealth and mental health benefits, but did not look yet on when we closed that gap, when we were able to close that gap, how many more people actually were insured. But that would be a really good thing to know, to learn. And this 1 in 5 adults is nationwide, not just Idaho. And what we have known is prior to close the gap, our Idaho numbers were much higher than that. So I'm sorry that I can't answer that question right now. I think if, Anna, if I can get some answers to you, can you get them to attendees?
Yeah, I can. I can just send out, I can actually download these questions and give them to you after the presentation, and I'll just, yeah, sounds great.
Yeah,
Awesome,
yeah,
thank
that
you.
would be great. Yeah, and that what we're going on about a year. We're in the first year, I believe, of that gap. And so it'll be interesting to see the numbers of insurers, of those insured over the next couple of years, because I do know it takes usually a couple of years for that to kind of catch up with itself. That's a great question. Okay, so let's learn a little bit about insurance so we know what some of this stuff means. Okay, one of my front office person that does all of our benefits and eligibilities always calls insurance a broken windshield, because that's kind of what it looks like sometimes. So in a nutshell, if I have, as a provider, let's say my fee is $125 an hour. If I network with an insurance company, I'm going to keep the math as simple as possible. So I just use $100 because that's easier for my brain to grab a hold of. So over here on the left-hand side, you'll see a pretty normal breakdown of a self-funded benefit plan. Okay, let's say I have a $5,000 deductible as a client. My benefit says I have a $20 copay, I have 20% coinsurance, and I have a $10,000 out-of-pocket max. We've kind of all, if you've been a person that's looked at your insurance benefits, you're used to seeing something like this. So as a provider, let's say the person that you go into to see, their fee is $125 an hour. They network, they choose to be in network with your insurance company, which means they can only, the amount that they're going to be paid the most out of any time they're seeing you is $100, okay? So that $25 we automatically take off the top every time, because we're not allowed to bill that. So you as a client, that deductible, you would pay $100, because again, that's your allowable, every time you go into the office until you reach that $5,000 deductible, okay? Beyond that, you're still going to pay 20%, okay, which is your coinsurance, which is $20. Forgot my dollar sign there, sorry. And a $20 copay. So if this is your plan, you're still going to, after you've reached that $5,000 deductible, you're still going to pay $40 per session until you reach that $10,000 out-of-pocket max. Does that make sense? I tried to make this part at least as simple as I possibly could. Most benefit structures work this way. Now, whether you have some co-insurance or just a copay, and when they talk about cost sharing, this is what they mean, is what is your, as a client, what is the cost that you're going to share on top of your monthly premiums that you're paying to your insurance company. Okay? So how do insurances do referrals and authorizations? So let's say I need help for an eating disorder. Okay. So do I have to go to a doctor first? Have my doctor say, yes, you need to see a specialist for an eating disorder. If they say yes, Now you have to call your insurance and get what's called a prior authorization, which is a number, and they attach that typically to a number of sessions or a number of days. If it's inpatient, let's say they give you 10 days, that's pretty standard, 6 to 10 days. And then treatment okay. Then they say, okay, yes, treatment is okay with this authorization number for only, let's say, 6 days from this date to this date of inpatient care. Okay, or okay, yes, it's okay with this authorization number for 10 sessions at an outpatient level of care from this date to this date. Okay, which means as a provider, every time that, let's say, 6 days comes up, let's say we know as a medical professional that you need 30 days in order to stabilize your body, okay? Which means every 6 days, your provider is calling the insurance company and getting additional authorizations for those additional 6 days, 7 days, 8 days of treatment. On an inpatient basis, they usually sit about 6 days at most. Does anybody have any questions there? Okay, so again, back to telehealth parity, what you're often going to see, and what I see, let's say in my parents' Medicare, is a different, let's say, copay than for primary health. So primary health copay is $0. For behavioral health, it's $10. Coinsurance, it's $0 for primary health. For behavioral health, it's $10. When it comes to authorizations for primary health, you don't need an authorization to be able to go see a specialist or to go see your doctor. You do need an authorization to receive substance use disorder counseling or an outpatient counseling provider. Does that make sense? So here are some of the common violations. I'm going to use that in quotes, violations that we see. So again, if your plan is subject to parity, and that's the tricky part, that's the part that's really hard to figure out, does my plan even have to follow parity? Once it's been determined, yes, my plan has to follow parity, then when do I know that there's a violation? Some common ones that we see is a separate deductible for behavioral health that's not part of the overall deductible. So again, this $5,000 deductible, one of the violations we see is, hey, you've got a $5,000 deductible for your primary care. You have another $5,000 deductible for your behavioral health, and they're separate. So when I go to the doctor and I'm paying and paying and paying, and I go to my therapist and I'm paying and paying and paying, and I realize, wait a minute, I've reached my $5,000 deductible, and I call and they say, well, that doesn't apply. The money that you've paid to your primary health care provider doesn't apply to your behavioral health, or vice versa. So it, in effect, doubles your deductible in a lot of ways. One of the violations we see is copay for behavioral health is much higher or higher than it is for other health care. That's what I was just talking about with Medicare and looking at my parents' plans. Limits on how many times a patient can see a behavioral health provider. My office currently has a case in with the Parity Tracker folks, because one of our clients, their benefit package came back that they were limited to 12 sessions per year for behavioral health. That limitation doesn't exist in their primary health benefit plans. Limits on how many days patients can stay in a treatment facility. This is residential care. It's one of the top violations because it's one of the most expensive. And so often we see benefit plans that only allow 4 or 5 days in a treatment facility, things like that, which would never be the case if you needed to be admitted to the hospital for some reason. Charge more for behavioral health prescription medication than other prescriptions. That one is consistent across the board. Oftentimes, insurance plans makes patients get their permission to continue behavioral health treatment. This happens by way of authorization, prior authorization. I've even seen insurance plans require you to call in as a client and meet with one of their counselors on staff before you're allowed to utilize their network of clinicians, before you're allowed to go see a clinician of your choice. Insurance plans refuse to pay for residential behavioral health treatment that a doctor recommends. We see that an awful lot. Doctor, by the way, being a behavioral health physician or primary health physician, both can recommend. Doctor recommends specific behavioral health treatment, but the insurer says less expensive treatment option must be tried first. That is a violation of parity. Insurance won't pay for behavioral health treatment outside of the patient's state or region. Again, a violation of parity. So those are some really common ones. Any questions we have so far? Okay, all right, I'm gonna keep pushing forward. So, how are we doing in Idaho, right? That's what we want to know. So here's a couple of links, and my hope is you guys, when we upload this to the website, that you'll just be able to click through. So one of the things that I did do when I was looking at just Idaho is looking at the state of Idaho behavioral health plan. And one thing that you will notice here, let's see if I can make it a little bit bigger for everybody, is the very exciting thing is mental and behavioral health is covered under essential health care benefits. So just so you all know, I pulled this down from their 2017 plan. This is the proposed plan to go forward through the year 2024 for any employee for the state of Idaho. So yes, mental health benefits are covered, outpatient services are covered, substance use disorders are covered. There's no limits. You'll see there's no limits, which is great. You will see there absolutely is a prior authorization necessary for any outpatient psychotherapy services after the 10th visit. So again, not a violation of parity. Why? Because this plan, government plan, is not required to follow parity. Does that make sense? Any questions so far? Okay. With respect to telehealth parity, there's not a whole lot to say, unfortunately. This site, ooh, I don't want to subscribe, thank you. Center for Connected Health Policy is a really wonderful site if anybody wants to see it. If we click here on Idaho, we can scroll all the way down and we can see a summary of what Idaho is and is not doing. So I'm going to scroll, and I'm sorry I'm going quite fast because I want to get specifically to private payer laws. So this is telehealth parity, and I'll scroll up for those of you who had questions about Medicaid. Private payer laws, you'll see no reference found. Really what that means is that there is, in a nutshell, no laws regarding telehealth parity and private insurers across the state of Idaho. They can cover it, they can not cover it, they can cover it at half the cost, they can do whatever they need to do right now. So if we scroll up though, you will see some of what occurred with the executive order. Idaho Medicaid specifies that coverage is available for only two-way live video between provider and participant. What that means is that store and forward, you guys, is really if I were to download some x-rays and forward them out for another specialist to read. That prior to the executive order was not covered, was not allowed. It is allowed now. Prior to this, it was only two-way. This policy, by the way, is old. You'll see it still says specifies coverage is available only for two-way. As of April, that is not true. That's what allows for store it forward. Connected health policy, let me go up here. You'll see here where it says that the new fall report will be available by the end of October. Okay, so my hope is that this will get updated fairly soon. Idaho Medicaid does reimburse for live video telehealth for certain providers and for specific services. Policy, there is another one. Hold on, let's see. Click for a list of eligible services provided in person. There is, oh, here it is. No reimbursement for use of equipment at either the distance or originating site. For those of you wanting to know, the distant and originating site for telehealth, the originating site where the session legally took place is called the originating site, and that's where the client is. So if I see a client in Oregon, this session took place in Oregon. The distant site is me. I'm the therapist. I'm the distant site. Okay. This statement, no reimbursement for equipment used at distant or originating site, is no longer true. Idaho Medicaid does reimburse for the originating site. The reason this is important is, let's say I'm needing to see a client in Idaho City. This happens all the time. Or Buell, or somewhere where access to internet or an access to the hardware, a computer, is really difficult. What we have done as a network, stakeholders really, is try to work out some creative options, solutions, and many providers will buy a computer or a computer system for somebody that is not their client to come in and get on to be able to talk with their therapist and get at least some reimbursement for allowing that space and buying that technical equipment. So it's exciting to see that Medicaid actually did, Idaho Medicaid did change this. So this is a little bit out of date, but again, they have stated that the 2020 data should be out by late October. We're kind of there. So hopefully that'll be coming fairly soon. So that at least is what's happening with mental health parity and telehealth parity across the state of Idaho. This quote here is actually directly from an email most recently. Just to be clear, there's no parity law in Idaho. That is our Idaho Insurance Commissioner Director, Dean Cameron. So Center for Connected Policy, as you can see, sort of echoes that statement. It does not appear that there is parity for private insurers for the state of Idaho. I find that curious because on a federal level, there is mental health parity with the exception of those plans that we discussed earlier. So as a categorical statement, I have a hard time understanding how that's true, but that's where we stand so far in Idaho. Does anybody have any questions so far or comments?
Not seeing any right now.
Okay, all right, great. Okay, we've got another video here.
One out of 4 Americans is directly affected by a mental health condition or addiction. That means you or someone you love has a diagnosable and treatable condition like anxiety, depression, or an eating disorder. Maybe you know someone seeking help for an addiction to alcohol or opiates. Mental health affects all of us. And like many, you probably rely on private insurance for your health care, including your mental health care. Getting the treatment for your condition can be difficult. It's not because you don't want to find a doctor and be treated. It's because when you do, insurance companies often deny your claims and leave you wondering why. It can be a mysterious and frustrating process for some, and even life-threatening for others. Has this happened to you or someone you know? You're not alone. It's happened to countless people from all over the country for many, many years, and it's time to put it to an end. You have rights under something called the parity law, and I'm here to tell you what you can do right now to protect yourself and get the care you need. But first, what is parity? It's important to understand because parity is your right. Let's take a step back for a second. Let's imagine that you had diabetes or heart disease. Your doctor would know exactly how to treat you, and your insurance company would know how to cover those services. They're in the business of healthcare after all, and to them, treating your illness now will save them money down the road. It's called prevention. What we do for physical health, we rarely do for brain health. It's hard to understand why. And as a result, insurance companies routinely deny coverage for mental health conditions and addictions, treating the brain as if it's not really part of the body. For a long time, they've gotten away with it, but under the parity law, they shouldn't. In fact, if they don't offer mental health and addiction services at the same level as other medical benefits, insurance companies are breaking the law. Parity is just a fancy way of saying fairness and equality. Your mental health care should be on par with your physical health care. No higher copays, no higher out-of-pocket costs, no unfair treatment limitations, period. What's good enough for the body should be good enough for the brain. And those denials of care I mentioned, well, they're probably a violation of parity, a law that's almost a decade old. So why am I telling you this? I wrote the law when I was in Congress because I saw what I still see now, big problems, shattered lives, and a fundamentally unfair system. In fact, I believe that access to mental health and addiction care is a civil right and something we need to protect and defend. If parity is indeed a right, then what does it mean for you? If you receive one of those denial letters, I'll bet you've asked yourself what you could do. For a long time, the answer was not much, unless you were willing to enter a bureaucratic maze that few actually came out of. Or you might try to hire a lawyer, but many of us don't have the time or money for that. But now there's a way to appeal a health plan decision. Those denials are not the last word. That's why I want to take a minute to walk you through this appeals process in the hopes that you'll use this information to get the care you are entitled to. Step 1, visit parityregistry.org, and there you'll find information on how to file an appeal and join our new complaints registry so we can work together to put an end to those denials. We need to show the insurance companies that we mean business. We can only do this if we have you and your friends and family members on board. Second, log your complaint in our system. We'll use it to show how many people are in the same position as you. We need to hear your voice and your story. That's how change happens. Third, use the website's resources to educate yourself on the appeals process. We won't be able to file the appeal for you, but in 10 minutes, you'll be able to learn how to do it for yourself. That power is in your hands. Fourth, exercise your rights. Share this tool with others and make your voice heard. Access to mental health and addiction care is your right, and protecting that right is part of our common struggle. We are all in this together, and I hope you will join me in taking on the unfair and illegal practices of the insurance industry. If you have questions, be sure to visit parityregistry.org. Send us an email. Thank you.
Okay. Any questions before we move forward from that?
I'm not seeing any, but I'll let you know.
What's that?
I'm not seeing any right now.
Okay. I love how passionate he is. And I also love that he's absolutely right in terms of what being knowledgeable about what actions that we can take when we see this happening, because going back to the Milliman report, I think that if we do see change, we're going to see it based on more grassroots efforts, and that can only happen when we're aware of what we're seeing, that what we're seeing isn't the way it's supposed to be. And that, again, is just the really tricky part, because like we talked about earlier, it's difficult to know when there is a parity violation. And some of these resources, the one that he gave and is at the end of this PowerPoint, and there's some other resources, it's a really good resource to help you understand and to throw it out to some of the experts who have been doing all of the research on the benefit on the insurers, the large insurers in each state, and can really tell you whether or not what you're being told is accurate. So from a telehealth parity perspective, and if you'll notice, we're sort of bouncing back and forth between these two things today, mental health parity and telehealth parity, that both of these really need to come along together at the same time. And why? Well, according to Health Resources and Service Administration, every county in Idaho, the entire state, is designated as a mental health provider shortage area, okay? With many Idahoans and counties having to drive several hours to nearest facilities. So in a lot of ways, if we are to provide really good quality access to care for every person across our state, we're going to need to be able to ensure the stability of telehealth services along with behavioral health and SED services as a whole. What are our current risks without telehealth parity? Because there, again, in Idaho, there is not. And I will get this number wrong. I'm so sorry. I believe Idaho is one of only 6, might be 5, states across the country so far without telehealth parity. So we really are lagging behind. And without it, we run the risk of reimbursement services for telehealth dropping as much as 40%. We have seen that in other states. So for providers who see in-person clients and telehealth, they run the risk of having a 40% reduction offering that services. So we're going to see a real cut in access to telehealth services for our rural communities. Obviously very important with what we're going through with COVID right now and really needing telehealth. Take COVID out of it, and it's very clear with as rural as we are that Idaho in particular needs telehealth to continue at the same rate. We run the risk that insurers drop telehealth entirely out of the benefit plan. So you could see your physician at any time, you could not use your telehealth benefits. We run the risk of insurers requiring a specific provider. One of the things we're running into right now is one of the largest insurers in the state of Idaho has been, prior to COVID, and probably will go back there, although yet to be determined, has been requiring their consumers use their own telehealth system and see their therapists if they're going to use telehealth benefits. Without parity, we run that risk again. Okay. Any questions there? Great. So where do we go for help? If you are a person, you get one of those denials that was being discussed, you can call your insurer, you can call the Medicaid program if it's Idaho Medicaid, and ask them those questions. Email the Department of Insurance. It's also called the Insurance Commission. You can email them. Their email is right there on their website. Ask them the question, let them know what it is that you're dealing with. Help them do that investigation. If it's VA or TRICARE, you can call their customer service. If you have Select Health or Blue Cross or whomever, you can call their customer service department. Those are really good first steps. And ideally, that's where it ends, right? Ideally, you call and you ask for an appeal, have them take a look at it. Hey, I believe this might be a parity violation, and that they correct the issue right there. If not, then we've got some other places that we can go to. SAMHSA, the Substance Abuse Mental Health Services Administration, has some really good resources on what parity is and what it applies to. The Council on Behavioral Health does as well. These last two, the Kennedy Forum and paritytrack.org, the two that were just mentioned, those are absolutely phenomenal resources, and paritytrack.org is a great group of people who can really help you make a determination about whether the plan that you're experiencing the parity violation with, whether that plan is required to follow parity. Because like I said, that, at least in my experience, has been the trickiest part of this whole thing, is not necessarily recognizing when there's been a violation to parity, but also, hey, has there been a violation to parity, and is this benefit plan, is this insurer even required to have to follow parity. And that paritytrack.org and the kennedyforum.org, those folks do a great job in helping you ferret some of this out. Folks, we are seeing a number of lawsuits. I wish I didn't have to go that far, but oftentimes these things are really kind of hashed out in our court system. We're seeing lawsuits across the country in various different states on parity violations. So again, it seems like these kinds of investigations are really important to helping make sure that this law does actually go into effect. And how can we help with establishing telehealth parity? You can. How do we do that? We call our insurers, we call customer service, we let them know we want telehealth and we want telehealth parity because we want providers who offer telehealth to stay in network. We need to talk to our HR departments, those self-insured plans, and let them know, hey, we want a plan that covers telehealth as part of our policy. Also talk to your HR department. Hey, does our plan that we're choosing as a company, does our plan is it required to follow mental health parity, SUDS parity? Because I really would like it to follow parity. We can write the governor's office, we can talk to our representatives, you can write an op-ed piece, as much information as we can get out to the public, ideally arming as many people as we can with information on what is parity, what can I be looking for that might be a violation to parity, and what can I do and where can I go when something happens, when I think something might be wrong, when a denial that I've received might be a violation of parity. Those things are going to be imperative, in order for us to really get mental health parity established as it should have been, right, 10 years ago, and telehealth parity going within the state of Idaho, but also a country. So that is all I have for mental health and telehealth parity. Does anybody have any questions or comments?
Hey, Kim, I know you mentioned briefly at the end of this presentation that there are several lawsuits throughout the United States regarding parity violations. We have a question that was asked right before that, but I'm just going to go ahead and ask it anyway, even though it's kind of related. In addition to a grassroots movement to help bring about change, have there been lawsuits even pending in Idaho specifically?
Not that I'm aware of in Idaho. There's two in particular that I've watched really closely. One was in California and one was in Indiana over the last couple of years, both of which the insurance company lost, which was profound because those insurers then had to go back, and two of them were insurers that we have here in the state of Idaho, although they are fairly independent of each other. But the idea being, when one of these insurers in another state realizes, hey, we have to follow parity with these plans, the idea being that very well may trickle in to our states as well, because, well, hopefully they don't want to keep ending up going to court. But so Indiana and Idaho are the two that I have followed over the past couple of years, because I believe at least to some degree will apply to Idaho. But as far as I know, there hasn't been a single one in Idaho. I could be wrong.
Okay, well, thank you for sharing. Kim, thank you so much for that presentation. I don't see any more questions at this time, but I'm sure people, if you're comfortable with people reaching out to you regarding.
I sure am. Yeah, and Anna can help you with my contact information. You can also just email me. It's Kim, K-I-M, at keyscounselingsolutions.com. And I'll do my best to answer whatever question that I can.
Awesome. Great, Kim. Well, we definitely appreciate you, and this was an awesome training. I definitely learned a lot. I know parity is kind of a complicated subject, so I appreciate having someone like you who's done so much research and is working to champion parity in Idaho. So I just appreciate you a lot. And this is recorded. This is a recorded training.
So everybody sees my screensaver. All my clients